to gain some of the time from the weekend. So what we'll do, we'll try to do it as efficient as possible. So the panelists will be discussing two related questions. And one of them will be, what are the challenges that they face in the practice in implementing precision oncologies, and what are the things they have done? What we'll be doing, we'll try to compile this information and hopefully come up with like consensus document or a paper or white paper. So what I will try to do it we'll try to do it in a very efficient way, where we'll start going in line, and every person will introduce himself first, and then he will address the question. We'll take 2 minutes each, and then we'll go through the whole panelists. Then will be, if there's any question we need to ask or something like that from the audience or input, we'll do it like this. So, and Nihal kindly agreed to lead the write-up in the end. Hopefully we'll come up with a paper very, very soon. So we'll start from actually this side of the table. If you don't mind to take a mic, introduce yourself, and let's address the two questions, the challenges of implementing. And by the way, we have, as you will see when they are introducing themselves, we have different experts, different backgrounds that cover different aspects of precision medicine. So start with introducing yourself, so people know your backgrounds, and then talk from your perspective, what are the challenges of implementing precision medicine in practice? Okay, go ahead, please.
Hello, I'm Leah Vasiliadis, so I bring a technical perspective. I do the Epic integration with our outside labs. I do a lot of the Epic build for our genomic module, our precision medicine program, and I've been doing Epic for a very long time. So I will try to not bore you with technical details, but I think we went live with genomic module in 2020. We put a big focus on precision medicine. Before that, obviously, the lead up to pick all the things that we were going to do. So what has been our challenge in the last couple years really has been the novelty of everything. So it's a matter of education, it's a matter of a lack of standardization, which would include the labs, the manufacturers, the outside vendors. How are they presenting you information? Are we getting the same verbiage? Are we interpreting data the same way? And then, of course, I think my biggest challenge right now is the optimization. So with the novelty of everything, we have constant changes. You never like that in terms of technical things, project management, or from the clinical standpoint. I'm sure it's not easy to have things changing all the time, but it is obviously very important for us to be able to respond really quickly to new technology, new lab tests, new components, and then how do I display that to you in a way that it's super usable, which would probably be my second challenge then, is adoption. Oncology is a little bit easier than precision medicine as a whole, I would say. So the things that I think we've found, and Karen hopefully can attest to some of this, but is really having dedicated resources. You're just not going to be able to respond the way that you need to if you don't have those. And then I think our biggest asset is having technical resources that fully understand the clinical aspect, maybe not fully, let's be honest, but can understand, the why are we doing it, how do I want it done, when do I want it done, and then what comes next, so that I can present everything in a way that is super usable and allows you to actually do something.
Okay, thank you, Leah. So pass it to Nihal.
Hi, my name is Nihal Rouby. I'm the pharmacist who helped with the pharmacogenomics implementation at St. Elizabeth Healthcare. So I will bring the pharmacy perspective, or I guess the implementation side of things. So I think I agree with you, and I'm glad that you went first with the Epic integration and electronic health record integration, because I think first of all, in my site at St. Elizabeth, we use an outside lab. We don't currently do the in-house testing yet. And so I think one of the challenges is to how to receive the data from this vendor, and how to integrated through the electronic health records and presented to the end user, so those are clinicians or the pharmacist, in a timely manner, and also have those results accessible at the time of the prescribing or at the time of making decision. Having the results accessible in an, I guess, easily retrievable place, because I know as time goes on, this particular patient will have lots of labs, lots of notes, and so it's not reasonable and it's not easy and feasible to just dig through the records, try to finding the results. So yeah, Epic integration is certainly one of the challenges, and I think having like a good support for that and having expertise like you to help with that, it will help definitely move the field forward. In addition, the other challenge, I guess, is
so we'll make the panel,
which I think we worked around it, so we can tackle the challenge and wouldn't be a challenge or a barrier anymore, is the clinical decision support. So I know that or we all know that clinicians, most of them lacked genomics training beyond the college years. And I think in oncology, it's a little bit easier because of the familiarity with the companion diagnostics and molecular profiling. So I think it's less of an issue in the oncology space. Yet clinicians are busy, and the time issue is important. And so whatever we do to present the interpretation and present the knowledge to them in an easy and precise way, I think the more we help with the uptake and integration of the genomics within the practice.
Thank you. I'm Karen Huelsman. I think I'm the genetic counselor on the panel here, so I'm representing TriHealth as a genetic counselor and also a precision oncology leader. And I knew even if I went first or second or third, somebody would already say integration with EMR. So I will say just the three things that I will outline certainly were harder pre-EMR integration and much easier post-EMR integration. But of course, as a genetic counselor, my number one issue would be following up on incidental germline mutations that are identified in tumor profiling. Back in 2013, when the genetic counselors at TriHealth first got involved with reviewing for incidental germline, we were looking at reports that had tumor-only solid specimens with no matched tumor normal. And so we were chasing down allele fractions and looking in ClinVar, trying to figure out when to follow up. And fast forward in 2019, when we started sending blood or saliva matched tumor normal samples, we started finding actual incidental germline mutations, and then we had to put in a process to follow up on those. And I think at TriHealth, our medical oncologists are very adaptive and innovative. They are really, very agreeable to working and collaborating with the genetic counselors to make sure that we follow up on germline mutations. And yesterday, I gave a talk about the role of genetic counselors, and I talked about incidental germline mutations. And we see these in 10 to 18% of all tumor profile tests, and at least 8% of those have actionable results for therapy. So I think germline is important. Not only for therapy, but obviously for family cascade. And so I think solutions that we've had at TriHealth include using a lot of telehealth through COVID. So I have entirely huge families that I've never met in person, but we've done cascade testing through telehealth. So I think those are some of the solutions to address the barriers of delivering incidental germline. My second issue, I think, would be relating to the broad and varied landscape of new precision oncology tests, whether that's early cancer detection that you talked so eloquently about, or whether that's solid or liquid biopsy or disease monitoring. There are so many tests, and it's so hard to keep track of what those are. And I can't imagine trying to be a medical oncologist or an ordering clinician and trying to keep track of the ordering process for each of those things. And at TriHealth, we have several labs that are integrated, and then we have several labs we use that are not integrated in the EMR. And so, we had to develop a one place, starting place for all clinicians for all tumor profiling. And so when we had this idea initially, we called it a master tumor profile, but now we just call it the cancer tumor profile. And so it's a single starting place for all clinicians to think about, what tumor profile test am I going to order? Is it an integrated, a non-integrated lab? Is it hotspot? Is it even early detection ctDNA? And those all have the same starting place in our EMR. So it drives everybody to one place, and I think allows the clinician to be very thoughtful about which test is it that I really want to order. Do I want hotspot? Do I want next gen? So that, I think, has been one of our solutions, as well as including a lot of education along with that. It's really hard for clinicians to keep track of what are the tests that are available, which one is the best one, and which one to use. So our IS team, I want to acknowledge Leah and Jamie Schmidl, made some great processes and tip sheets to help that along. And then my third issue, which I'll not talk as long about, is health equity. So pre-EMR integration, I think this was really hard to tap into. Are we offering tumor profiling equitably or not? And now that we have a lot of discrete variables and ways to track measurable outcomes with the integrated EMR, we were able to demonstrate statistically that we're offering tumor profile equitably with regard to race, age, and gender. And I think the solution for that was definitely the integrated EMR that drove that. Thank you.
Thank you.
I like how the girls are sitting here and the boys are sitting. High school dance. It just sort of happened this way. It's actually funny. I already talked too much today, so I'm not going to say too much, but everything they said, I think I completely agree with. There's the issue of cost, the number of tests that are available and how to choose among them. And I think the biggest issue is that we're the generation of transition, I think. So we have, these tools that weren't available before. These tools are generating reams of data. The problems of where we put the data, that's one thing. How do you even begin to read that information and get it synthesized in your head? But even if you do, we really don't know what to do with it, right? So everything is happening so quickly. There really are no guidelines for what to do with it. So I use the phrase that we're building the plane as we're flying it, because that's what it really feels like. And we, there are those so-called experts because they probably do this more and think about it more, but it's not that we all have that much of an individual experience with it. So forums like this, so thank you for organizing it, I think are critical for us to get these issues out there and to think about what the right next steps may be, because I really don't think they're clear at all.
Thank you.
Great, thanks. So now to the other side of the gym at the junior high school dance. You heard me, maybe you heard me speak yesterday, and maybe you even stayed awake for the whole thing, but I'll reiterate a few things. First, I'll refer you to a publication that we had just over a year ago it's from the Personalized Medicine Coalition. I sit on the executive board there, and we talk about all of the things that are necessary for the implementation of precision medicine. And the number one thing is to have a C-suite champion. And until your hospital or your system has a C-suite champion who can help you be the storyteller to get the investment, it's not going to happen. Then I would move on to basically what you've heard before. Hereditary disease risk screening is incredibly important. And I was cited in an article that I saw earlier this week from a question and answer period that said something I think that maybe could be said more eloquently, but I think it's important, and that is that getting a physician to pay attention to another alert is like getting me to lose 10 pounds. It is not easy. So implementation is incredibly important. And doing it through just a straight BPA, I think, is difficult. So first, I think it's really important for us to have embedded clinical decision support and artificial intelligence tools. These will help us evaluate which patients should be receiving hereditary cancer testing, for example, or which patients, clinical decision support tools with artificial intelligence, should be getting molecular tumor profiling, so that everyone is getting what they should. The implementation then needs to be interpreted by people who understand. So hereditary disease risk, interpreted by a genetic counselor. Pharmacogenomics, interpreted by a pharmacist. A pharmacogenomic trained pharmacist. There are a few of them. There are residency programs in the United States that graduate 10 of them per year. We're creating our own starting next year. We're going to grow our own. It's really important. And then third, the molecular tumor profiling needs to be interpreted by someone who understands it. And right now, I'm not sure who the perfect person is for that. Genetic counselors, with all due respect, are not trained in somatic testing results in their training. Pharmacists are not trained in interpreting genetic results unless they go through pharmacogenomic training. So finding the right people to interpret, I think, is incredibly important. So for me, the implementation is critical. And finally, what everyone else has said, embedding it in the EMR in a cognitively simple way with clinical decision support for everyone who looks at it is of the utmost importance. But even doing that, you still need the right people to interpret it and help the physicians understand. A primary care doc during the pandemic has been hit over the head 500 times with new things, and giving them another alert might not be the right way. So we need to come up with ways to implement so that everyone has raised awareness on how we do this. So that's my speech, and I'm sticking to it.
Thank you.
Okay. Again, I'm Matt Bramlage. I'm the director of cytology at TriHealth. So I bring the pathology, the laboratory perspective, and my 2 points are very, very, very practical points. You guys want tissue. So we have to make sure we have tissue that's proper, enough tissues, and that we get it, to the correct lab on time. Turnaround time is very important. So just the very basic things. We realized that our Q&S rate was 25%. We were worse than the national average. And so we undertook a project to try to figure out why, what we could do. Obviously, it's easy to tell radiology we want more cores, but one thing we were realizing very soon is that we were doing so many immunostains on core biopsies that even if we asked them for 3-4 cores, if we embed them all in one paraffin block, we often cut through the tissue. So we came up with a protocol where we would ask for 4 cores, and I need to back up to say we always send a pathologist to every adequacy to make sure this is viable tumor, it's not necrosis. Yes, we don't send a cytotech, we always send a pathologist. I mean, we're the only, I believe, I could be wrong about this, Burns could correct me, but I don't think any of the hospitals send a pathologist for their adequacies. They usually send a cytotech or nobody at all. They just, just the radiologist or whoever does this. But we go to the endoscopic procedures, the pancreatic procedures, we go to the CT procedures. So, we're making assessments too. Is this a lung adenocarcinoma? We know we're gonna need a lot of tissue for that. But if I look at it as a small cell or squam, I know I'm not going to need necessarily as much testing that. So we want 4 very good cores, and then we decided to embed them in 2 tissue blocks. So one block we're going to cut, and we're going to use that for IHC. But the other block, we're going to do an H&E to make sure, but we're going to leave that intact. And that changed everything overnight. We went from 25% QNS to 11% QNS. Just by doing that. So that was, it was very simple. It seems straightforward, but we did a lot of it. We did a lot of phone calls, a lot of investigating. No one had a very good system. That's what we did. So that's one thing. And then in terms of turnaround time, we realized that this matters because we have requests coming in. We don't do our own testing. This is all going out, but we have requests for patients taking their cases out. We have tumor board. We have so many different things coming in. We have a pool of secretaries. We have people pulling. So it's maybe 3 or 4 days before a block goes out. So we realized a few things, that when we're signing out a case, we actually have created a discrete field in the report for which tumor block is the appropriate block to go. So we know that there is one, or if we decide that case does not have sufficient tissue, we will designate that. So we know immediately when you look at a path report that there is a block appropriate for molecular testing, and maybe even one that's been set aside specifically for molecular testing. So when that request comes in, they can immediately go and pull that block. And we don't have to pull the case. We don't have the issue of sometimes we would send a case, it's the wrong block, it doesn't have enough in it, they ask for another one. We've avoided those requests because we've already specified a block that needs to go. So we've done that, and I'm trying to think with the other things. And the last thing we did, we actually finally got funding to get an FTE. So we have one person really at all times that's in charge of molecular testing. It's not going to the pool of secretaries. We have one person, and that's key because not only do they start to know the different tests, and they know that they get a request that's not going to work, or that's the wrong request, or that's the wrong type of tissue, or something like that. So they can bring that to our attention very quickly so the wrong thing doesn't go out. But that person can, and because you have that process, the request comes in that day, we have one person taking care of it, a block's been designated, they can get that block out that morning. It's, so we went from, I think, maybe a 3 or 4 day turnaround often to, I expect it to go out that exact same day. The block's been specified, we have a person taking care of it, they know all the labs that we're associated with, and it just goes out. So I would say that those are probably the most important things.
Thank you.
Ditto. No, I'm just kidding. My name is Andy Guinigundo. I'm a nurse practitioner. I was initially a bone marrow transplant nurse for 5 years. Then for the last 21 years, have been a nurse practitioner in a private practice in the community. Now for the last, let me think.
8 hours?
2 days. I've worked with Dr. Jazzy and Dr. Lemming and Jill Hunt as a member of the team at Cincinnati Cancer Advisors. So I'm not sure I can give you a great perspective on that practice, but let me give you kind of my overview of what I think, from my perspective, what needs to happen in precision oncology. There are not enough of us trained. So if you were to take, say, someone suggested we should be testing all breast cancer patients for germline mutations. Okay, that's about 300,000. Let's do prostate. That's very close to 300,000, and ovarian, and pancreatic, and endometrial, and colon cancer. We're getting very close to 1 million new patients a year, and there are only 5,000 Karens, right? Only 5,000 GCs in the country. So we need more people who are trained and specially trained. Dr. Jazzy should be having to rent out the space next door at the convention center to be able to train all of us to do precision oncology. That's not happening today, and as the hour gets later, there's less of us here now, but that training needs to increase. Secondly, what was my second point? See, I have it right here. Testing. Test. If we walked out these doors here and talked to any of our pharma colleagues, what is their emphasis? So any of these drugs that we are thinking about with precision oncology, we can't give any of these brilliant new drugs without knowing what the testing is. And so we saw this morning they presented the slide from ASCO last year, abstract, actually as part of the network that I was in. And we were only testing for actually less than 50% of patients who should have been tested were being tested. So that's all comers in a lung cancer setting. And that number should obviously be 100%, so that's not there. If you were to take, you flip the page to the next abstract in ASCO last year, it talked about racial discrepancies. And there was a greater than 10% discrepancy between white patients and black patients being tested. That needs to change. And I saw many demographic information. It's one of the slides that we like to click through really quickly when we present pharma slide decks. But I saw one earlier that was NTREC, and it was like 67% of the patients on that trial were white, and low single digits were Asian, low single digits were black. I give the slide deck for sotorasib, and I think that the white is like 80%, and so that needs to change, obviously. And we heard what Karen was talking about with that integration into the EMR. That's awesome. If that's all it takes is a technological fix, that's amazing. So that brings me to my last thing. I see what Christ Hospital is doing. I see what TriHealth is doing in terms of integrating these results into Epic. A couple decades back, whenever you added a printer to your computer, you added a modem to your computer, and they used to come separately, if you remember. You added a keyboard, a mouse. you had to download drivers and do all these things. But they came up with this USB port, Universal Serial Bus. You plug it in there, they called it plug and play. Now, it didn't always work great, but it was all about plugging it in, and hopefully you start typing in it, you start seeing letters on the page. Well, Epic's awesome. I love Epic. But what if we had a platform agnostic and a lab agnostic system where we could just plug it in there and say, well, we're sending results over, and boy, they're going to be in discrete fields. You know, maybe I'm dreaming, but we already heard all the reasons why that's necessary in terms of research, in terms of just saying, gosh, maybe I did that test on that patient 5 years ago, maybe not, but oh, there it is right on my dashboard. And then regardless of what system you happen to be running. So I think those are the three things I think that need to happen moving forward.
Thank you, Andy. So, well, without money, we'll not be able to do anything. So we'll hear from Sarah what she thinks.
I'm adding to the girls' team over here. I just wanted to comment really quickly on following up on the cost concern.
Is it working? Yeah. Yes.
This thing on? The cost and reimbursement concerns are just, it's massive. So how far can we get if we're not able to, if the labs and the clinicians that bring this in-house, which is happening more and more frequently with next-gen sequencing, if they can't get reimbursed or if there's really high patient costs. So those I really combine. Again, we saw some of the numbers yesterday. When these tests are thousands of dollars, even when they're paid, if there's a co-insurance of 20 or 30%, I mean, that's a real concern to clinicians because it's critical for the patient, but it doesn't come without potentially high costs. And so it's also getting so that the patient understands the value of that. I know one thing, if there's an actionable target or something comes of it, the hardest ones are where there is nothing. And sometimes prognostically it's not good, or sometimes nothing was found at all, and they still get that bill. It's regardless of the result. So it's critical to run the test, but the education as far as patient costs and concerns, I'm sure you're getting constantly, clinicians are getting pinged from insurance companies, or there's just issues around billing where I'd love for the noise around that to subside so that the true patient care can be focused on, and not so much the cost or the noise around the payers or saying, I want this for my patient, but they will not allow access to this. That's got to expand. And that couples up with my second highest concern is the innovation. So I think that it's incredible, and it's great that we have all these options, but the amount of labs, the amount of specialty labs, single labs doing single things, again, when it comes to integration, when it comes to billing, when it comes to patient understanding, it's at an all-time high, and that's a blessing and a curse. It's so great to have those different options, but it's hard to understand them, it's hard to integrate them, and it's, again, every lab has a different policy, every lab is with different payers. It's just confusing. And there's really no standard of testing, as we even saw yesterday. Medicare treats, this type of genomic profiling differently in each region. Payers treat it, almost none of them cover comprehensive genomic profiling today, almost none of them. Even though it's very, it's critical to the patient, it just hasn't reached the point where it's being completely understood or paid for. Maybe, there's FDA therapies on the other side of that. So you could have an FDA-approved kit run on an FDA-approved machine with an FDA-approved therapy on the other side, and that test will still not be covered. So I think there's a long way to go in building that reimbursement environment so that A, we get paid more frequently, B, we kind of cut down on the noise from the payers, C, the patient costs go down because this is just so standard. I think some of these great early detection tests are amazing, but there is zero coverage for those right now in some cases, as we've heard. So are patients willing to pay out of pocket for that? I think that can only get as far as the patient's willing to spend at this point. So expanding that, because downstream, there really are benefits to having this early detection. It's less repeat costs, less hospitalizations, less therapies down the road if you can catch it in earlier stages. So I think it's building the studies and building the trials to kind of show that data. So that's where I think everyone can join together to say this makes sense. Catching it early it may seem out of pocket today. You know, we're talking about, they won't pay for one. We're talking about maybe doing that yearly. We're just a ways from being able to have payers look to pay for that. So how do we reach that? And I think that that's all really working together to show that early detection will not just benefit the patient, but it will benefit the bottom line of the payers downstream. But it just hasn't really been shown accurately today in a way that payers are listening. So we really all need to, it shouldn't be a focus. It shouldn't be something that you guys all have to pay so much attention to, but it can literally stop some of these tests in their track. If they can't get, you know, I've heard great tests have great clinical use and doctors really want to use them and they're just not covered. And that's just a challenge for everyone. And again, you don't want to AMR interface every single lab that's in there. It's just, there's a cost to that. There's a trouble with that. So I remember I worked for a lab that had one single test and it was so, another lab? You know, it was like when you go in to talk about it and it was a critical, you know, it was a space that didn't have a lot of coverage, but, and yeah, the innovation is just trying to keep up. Every day there's new guidelines, there's new clinical treatments, there's new clinical trials. Whoever you're using for that clinical genomics workspace, whatever lab or if you're interpreting yourself, you have to keep up with that on the other side, and that's incredibly difficult as well. So just that innovation is difficult.
Yeah, thank you. So Burns, you have something to say?
Yeah, so I had the pleasure this week of sitting through, there was a great meeting in the Netherlands, and so that means getting up at 2 in the morning for the start of the meeting. But there was a fascinating meeting this week about universal precision medicine. And they went through the actuarial math of what you're talking about. And you may have already suspected my bias by what we're doing. We're doing the world's first prospective randomized controlled comprehensive pharmacogenomic study where we're testing literally every gene that is approved by CPIC guidelines. And we're seeing reductions of minimum 20 to 30% ER visit hospitalization. So what this group did, and there's a really nice set of publications on them, is that they showed, and they do all sorts of things that none of us like to think of, like assigning dollar amounts to a year of life saved, which is kind of rough. But at the end of the day, the biggest bang for the buck right now in precision medicine is, anybody, Bueller? Pharmacogenomics. Number 2, hereditary disease risk evaluation. Number 3, testing, prospective testing through blood. And number 4, sad but true, is the companion diagnostic test for a new medication because it costs so much. And I'm not advocating for ditching any of those, but what I would advocate for is that if I clearly am drinking the Kool-Aid, but pharmacogenomics can make a huge impact if you have an appropriately embedded clinical decision support tool with pharmacogenomic trained pharmacists who can inform. Tamoxifen, 20% of patients are going to have a mutation in the gene that makes it an active drug. So if you want to be giving preventative tamoxifen to a patient who's getting no benefit out of it, I would recommend against. So there's all sorts of benefits. Yeah, I'm sure you have a comment there. But you know, all the other medications that our patients are taking, whether emetics, antidepressants, et cetera, there's a lot to do there. I'm not advocating for not doing anything else. But from a simple, heartless financial perspective, from the data, universal pharmacogenomics can actually have a huge impact. And hereditary disease risk is number 2. And if we can get and capture those patients, then we'll have to do slightly less of the implementation of 3 and 4.
Yeah. So I think, this is, probably the pharmacoeconomic and cost effectiveness in pharmacoeconomics. Cost effectiveness, studies and so on showing that the financial benefit to payer will be the way to go. Does anybody from the audience has any questions or comments? Let me ask you a question for, so now, when pathologists have breast cancer patient, they do ER/PR without asking the oncologist to do that. When are they going to be able to do genetic testing without getting an order from oncologist? So, no, what I'm saying is that, now we have many markers that are known clinical benefits and so on. And, it seems like, if you are looking at ASCO data, only 50% of lung cancer cases, they order molecular testing on them. So when is it going to become routinely done? What does it take to make it routinely done by the pathologist without asking an oncologist or to order it? Because we don't order ERBR, right? It's part of the profiling. So between Dr. Liu and, okay.
We do whatever you ask us to do, but I think the breast cancer makes, every single patient with invasive breast cancer is going to need an ERP or HER2. So I think we've had cases where we've had situations like lung cancer where we've had times where we've had upfront testing, but then it's turned into this thing, well, some of them need the EGFR, some of them we want to do next-gen sequencing. So all of a sudden they stop because, well, we want some of them to have this and some of them to have this. If they all have the exact same pathway, that's one thing. But if they don't all have the exact same testing that you need, then I don't think we can do that.
I would agree. Until it's universally needed, then it can't really be automatically requested. And the other issue is just, and you raised this before, it's the use of tissue. So one of the problems we have with reflex ERP or HER2 testing is that any time it says breast cancer on the requisition form, that's done. But in someone where we're specifically getting the biopsy for next generation sequencing, you've already used a bit of the tissue. Now, gratefully, you're processing it differently, right? And to help preserve adequate sample for sequencing, that isn't always done. So part of it is derailing the train where there is automated testing, so that becomes a problem. And because we're so nuanced now, it's hard to set that path for everything has to be done when you want to be nuanced, just like with lung cancer, EGFR this or not, or whatever.
Okay.
So we will, though, I think, get to a day where everybody's just going to get sequenced. So the questions we have now. Yeah, exactly. Right? I mean, hopefully no one's getting somatic testing because it means they have a diagnosis of cancer. But germline testing, I think, is going to be done, helping with pharmacogenomics and the hereditary cancer risk.
Okay.
Yeah, just to the everyone's being sequenced. Thank you for the segue for my question. My concern is we have these groups. Orion is one example. It's Moffitt, Ohio State, I think, started it. Many more have joined on. Geisinger is doing it for their complete population. City of Hope's going to do it, the whole genomic testing. So who's going to take care of that information? Who's going to come to the patient and say, this, I know Mike Caligari, who's the president of City of Hope, and I talked to him when I was at one of the meetings, and I said, so how do you get that complete release of all that for the patient, the medical ethical part of that? And then my last question, if nobody's going to take, we don't know who's going to take care of it, my suggestion would be Matt Bramlage, because AI is going to take his job, so he can just do that, right? No, I agree. Matt's been great on that. So just thoughts on that. I'll sit down, but what are we going to do with all that information, and who's going to be the, and where's it going to go? It brings up the whole privacy, and anyway, I'm getting frustrated by the question I'm asking myself.
I'm happy to start. There's a lot smarter people up here to address this. So, random fact, the woman, the Congresswoman Louise Slaughter, who put forward the Genetic Information Non-Discrimination Act, is actually one of my very close friends, and it arose out of grocery store conversations when I was living in New York. The problem is that bill got watered down in Congress to not protect long-term disability, life insurance, et cetera. So we have a problem in this litigiously saddled country. And so all of these systems are doing sequencing on their patients, but there's still potential for litigation for things that won't be covered. So I would love for there to be acts of Congress that protect that more. To your question of who takes care of the data, so genetic counseling 10 years ago, you could barely get anyone to do it, and now everyone's done 23 and figured out who their dad isn't, or is. And there's a lot of appetite for the information until they understand the implication. I think it's important for us to educate the public that it's okay to take ownership of their genomic sequence and be an advocate for themselves. So if you have an artificial intelligence tool that can interpret the data and make both the physician and the patient advocates for preventive care, that would be the biggest bang for buck. And I will tell you, it'll probably be easier to educate the patients, because Dr. Dougal does a great job, and that's why ivermectin's a great drug, for example. Sorry. Do you want to talk religion now, or okay? I don't know that we can rely on every physician to become trained in how to do this, and that's why it's important for us to have EMR integration and then educational programs and specialists who help everyone with this. Sorry if that was a long-winded answer, and I'm not sure it's an answer at all, but it's a start.
I'll also comment just from the genetic counselor standpoint. You know, it's often cited there's a shortage of genetic counselors. There's not enough to address, you know, all the people who need genetic testing. And I think genetic counselors have really flipped the paradigm where we don't want to spend as much time in pre-test counseling. You know, I would be very bored. It would not be a good use of my time to talk to somebody who has a family history of a mom with breast cancer and spend an hour talking about that. And so, you know, we've flipped it where genetic counselors are spending more time on the more complex cases, using ways of high throughput to get testing accomplished. There's chat bots, you know, I'm sure you've seen them with Invitae and AmbriCares. And so there's a lot, you know, more efficient ways to get more people tested and allow genetic counselors to work, you know, a higher level in their abilities. And I also think, you know, with the integrated EMR, although, you know, we talked about alert fatigue, I think the practice care alerts, you know, that Leah has been helping us build into our EMR are certainly helpful in getting the patients, you know, connecting the dots between a new germline mutation and, you know, all of the things that they could or should be doing based on that.
Well, I just wanted to weigh in on both of these comments, I guess. We definitely, all of us seem to be advocating for early screening. What can we do for routine care? How can we be talking to these patients? But it's exactly this problem that we have is we do have a fear, right, of we have this data now, we have this information, they did a chat bot, they did whatever. Hopefully they take some ownership and they have that education and they do it themselves. But if they don't, where does this go, you know, in the EMR? And I guess that's kind of where we are at, is we're trying to roll out testing for everybody that comes through for one routine thing. We want you to be educated and have the opportunity and know what you can do. However, we have to think about what we do in the long term if you come back to us and no one acted on a potential score, which isn't a guarantee for anything, right? But if you have that result in there, nobody takes action, the patient doesn't take action, and something happens in a year or two, now what? So I don't know, it's just a challenge that we've been addressing. I don't know that we have the solution, but.
So can you imagine if I complicated the question more and the patient does not come just for oncology testing, come with the whole genetic testing for everything, and then he has risk for cardiac disease, risk for something else, and I think eventually it will end up being the whole healthcare system. The internist will take care of something, the cardiologist will take care of something, the oncologist has to take care of something, because we're talking about just one part of the personalized medicine, the precision medicine, the oncology. And the field is going where you are going to have tests bigger than us, the oncology, and then somebody has to handle it. And I think it's going to be disseminated across the healthcare system, and every person, based on his specialty, will be taking care of the patient.
Yeah, absolutely. There was actually a study done where 10,453 patients were given a prospective healthy patient screen test that covers cardiovascular, cancer, and heritable monogenic diseases. Yeah. And collectively, over 20% of the patients had something.
Yeah.
So there's a lot to be done in proactive screening. But Karen, I did want to address one thing you said. I don't think it's possible to underestimate the value of the pre-test counseling for a patient, because sitting at home and just getting a BRCA2 positive result that says you're at a great predisposition for this really terrible disease process is not a nice thing to do alone. So I think I don't want to undervalue the importance of genetic counselors, because it's not just genetics that they do, It's also the counseling, and I think it's of incredible value to our patients, whether it's virtual or in person.
I